look for, even for experienced nurses in my department. Like, you can have a ton of clinical experience. You can be a clinical expert in everything under the sun. But if you can't be nice, then you don't belong in my department. Like, you have to be able to treat people the way that we want to be treated, and you have to be nice.
Yep. Nobody ever complains about clinical skill. 100% every complaint I've ever taken, even, maybe not 100%, but 99.8% of complaints are all about behavior and how people made people feel.
Yep, totally.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
You may notice that today's episode sounds a little bit different. That's because I'm finishing up this episode sitting in the airport in Dallas, Texas. So I apologize in advance for the noise and hope you understand. This week's episode, I have an interview with the 2020 ENA president, Mr. Mike Hastings. Not only does he share his experience as an ER nurse, but at the end he shares a little glimpse into what his focus will be as president. Before that, I want to remind you that if you haven't done so already, please leave a rating and review of the show in your podcast player of choice. Doing so helps the podcast get noticed in podcast players and makes it more discoverable for other nurses. Also, don't forget to share this episode with people that you know. Your sharing with your peers is the number one way the show grows. I appreciate you listening and want to remind you that you can interact with the show on the Facebook page by simply typing in The Art of Emergency Nursing in Facebook. This is a great place to ask questions, interact with the guests, and suggest any people you think I need to interview. Thanks again, and enjoy this episode with Mr. Mike Hastings. I'm going to start by asking you to introduce yourself, tell the audience a little bit about you, a little bit about your experience, what you've done, and what you're doing now, and then go from there.
So I'm Mike Hastings. I'm currently the manager at Swedish Edmunds Emergency Department in Edmonds, Washington, so just north of Seattle, about 30 minutes. So I manage a community-based hospital here. So we see about 150 patients a day. Prior to being here for the last 3 years, I managed a freestanding emergency department up here in Washington as well. And then prior to that, I was down in Texas in Austin I was a trauma manager for pediatric level 1 trauma center. Went through their ACS survey with them. Got them recertified, and prior to that, I was in Kansas City, working at University of Kansas Hospital there, in multiple roles. Started off as a new grad in the ED, and then worked, did hyperbarics, did quality work. I was a sepsis coordinator, leading our sepsis initiative for 18 months. Did a bunch of research, and then prior to leaving there, I was in charge of our quality and research for the emergency department, working with our physician partners in nursing for research and quality, just focused in the emergency department.
Nice.
So that's kind of professionally what I've done. And then prior to that, I was going to say, even prior to that, I did 10 years of EMS work. And then actually my first degree, though, was actually in criminal justice. So that's kind of where I started.
Really?
Off at, yes.
What was the goal with the criminal justice degree?
Well, so my goal initially was that I was going to go into the FBI, or that I was going to be a detective. So all my criminal justice studies really were around vulnerable populations. So
nice.
I really focused on domestic violence and child abuse stuff, and so that's where I kind of specialized my training in. So yeah. Wow.
And then, how did you get into nursing?
Well, I actually got, it all started when I was 16, when I was in Boy Scouts, actually. I did a ride-along with an ambulance service. So one of the dads, he was a paramedic, and so he was able to get me to do a ride-along. And so I did a ride-along, and I thought, oh, man, this is really cool. The adrenaline rush and all that was awesome. And so when I was 18, I got my EMT. But there's not much as an 18-year-old EMT that you can do.
No one's going to let you drive and stuff.
Yeah, you can't drive the ambulance until you're 21 because of insurance. You can't work in the casinos because you're not 21. So I did a lot of volunteer work with the Red Cross. And then I thought, well, this is fun. I can do this on the side. I can still do my law enforcement stuff that I want to do. And so that's the track that I was going down was law enforcement.
Nice.
I worked for a sheriff's department, and sheriff's departments are political. And so I played the political game. It was one of the things that myself and another officer stood up for safety. And the following day, we were both let go.
Wow.
And so that's, I actually then started working for a rural EMS service as I was finishing my degree, because I was still going to college, still finishing my degree up in criminal justice. And then I just kind of went down that track of EMS and really, it was a lot of fun, enjoyed it. And so then it just kind of one thing after another led me into nursing. So
Nice. At what point in your career as a nurse were you like, okay, this is what I was meant to do. This is where I'm supposed to be?
Really kind of honestly when I was in nursing school, and I just knew because even when I was in the field prior working EMS, all my partners are like, yeah, working on the ambulance, are like, you need to do more. There's more to you than just working on the ambulance. And then going to nursing school, I was like, yeah, I really could do this. And it was just always rewarding to be able to help people out and, provide care to them. And it was funny is because it seemed like every rotation that I was doing during nursing school, my instructors were like, or my clinical instructors were always like, yeah, you're a really good fit for this, right? So my OB rotation, the OB nurses loved me. They wanted me to try to come work with them. I was like, no, this is no way. I'm working OB.
You're like, no, I'm good. Thanks.
Yeah, thanks. But I always kind of knew that the ED was kind of was calling me because I want that short-term satisfaction and always having something new, something different. So I landed as a new grad in the ED and have never really looked back. So
that's awesome. So I was going to ask you about that. So you started as a new grad in the ED. What are your thoughts on new grads in the ED? Was it a good thing? Was it a bad thing? Is there if you were to go back in time, would you do it again? Would you start as a new grad in the ED?
Yeah, I think to have new grads in the ED, it's great if they have some prior experience. Have either working in the ED, so they kind of know what they're getting themselves into. If they've done at least, hopefully, their senior practicum in the ED world, give them some exposure, and really to make sure that there's some sort of robust residency program that there is to help support them and guide them. So, where I'm at currently today, I hire residents into my ED. And so those are the things that I look for is, do they have that experience? So that way they're not just saying, oh, the ED is like what it shows on TV, because we know the ED world is not like anything like TV. So,
yeah, it's not quite.
Yeah. So even in Seattle, it's not like, Grey's Anatomy or anything. So.
So when you're hiring nurses for your residency program, what exactly do you look for? You said you look for experience. What else are you looking for?
I really look for a personality fit. My philosophy of it that is that I can teach them clinical skills, but I can't teach them how to be nice.
Amen.
And it's just the basics. And this is what I look for, even for experienced nurses in my department. You can have a ton of clinical experience. You can be a clinical expert in everything under the sun. But if you can't be nice, then you don't belong in my department. You have to be able to treat people the way that we want to be treated, and you have to be nice.
Yep. Nobody ever complains about clinical skill. 100% every complaint I've ever taken, even, okay, maybe not 100%, but 99.8% of complaints are all about behavior and how people made people feel.
Yep, totally.
100%. That's what's going to matter. So.
Yep. And the patients aren't going to remember that, it took them 3 sticks to get an IV. If you made them feel nice and welcome and that you cared for them, that's what they're going to remember.
Yeah. Yep. I walked into a patient's room last night. And I'd seen her a week before, and got an IV on her, and she was kind of fighting and didn't want another IV because everyone had a hard time, and she'd been poked a bunch of times, and I hadn't seen her since. She was still in the hospital, and I walked in the door, and they're like, "Oh, you got to come see this woman. She looks terrible." So I went up there to go see her, and I walk in, and she's like, "Oh, I remember you. You're the one with the jokes." Because I was telling her jokes as I was starting the IV, keeping her distracted.
Yep.
And I go, yep, that's right. I'm the one with the jokes. I'm here to tell you some more jokes. And she's like, "Well, you can't poke me again. I already got a pick line." I'm like, "Okay, that's good." And I was like, "But I got to tell you, all jokes aside, you look like crap." Because she did. She started laughing. She goes, "Yeah." She goes, "I guess I kind of feel like crap too." And I'm like, "Okay, let's get you taken care of." And it just kind of lightened the mood, and everything was good. And she hadn't seen me for a week, and that's what she remembered. And I was like, "Okay, that's kind of cool." So
yeah, and again, it's that, and they're not going to necessarily remember your name or anything, but they will always remember that you took the time and how you made them feel.
Yep, you're absolutely right. Absolutely right. All right. Tell me about a patient who changed the way you practice.
Well, there's been several throughout my career so far. And, there's one, and so kind of just building upon what we're talking about. So I was actually, during my last phase of my residency program as a new grad myself, I had a patient. So she was a pediatric patient that was normally seen over at our children's hospital. However, her neurosurgeon had transferred his services over to our hospital. And so she was coming in, she was having problems with her VP shunts. And so, of course, I need to get a line on her and stuff so we can get some lab work, and then we're also going to do her x-rays and all that jazz for her. And so just by sitting down, talking to her, she was quite anxious because this is not a familiar setting to her, where she had been used to being going to the children's hospital and everything. And so you could tell family was a little anxious about her. And so I'm just trying to go get the IV, and they were like, "Well, she's a hard stick. Normally we have to get the IV therapy team to come down and see her." And of course, this is nighttime, and at night at the hospital, we were the IV team, the ED nurses, right? So I said, "Okay, well, I'm gonna just take a look. I'm gonna talk to you during this whole process, let you know. I'm going to take a look. If I don't see anything with you, that I feel comfortable in getting for an IV, then I'm not going to do it, right?" And so just, excuse me, just kind of explaining to them what was going on and what I was doing, you could see that anxiety factor just totally decrease in them. And I was able to get the IV on her, and she was like, "Wow, you got the IV?" I was like, "Yeah, and I was just taking that time and explaining things. Yes, it took me longer to do that. However, it was more successful in the long run, right?
Yeah.
And so that really, just at that moment, like the way that her family and her interacted with me and really appreciated me taking that time has really kind of helped drive that message home to me. And so with every patient that I interact with, I try to make sure that I'm taking that time and connecting with them as an individual person, because when they're in our department, it may not be an emergency to us, but it is an emergency to them, right? And that's why they're seeking their care to us. So, and that's what we just always have to remember.
Yeah, absolutely. Tell me about your first med error.
So my first med error was actually on a pediatric patient as well.
Oh.
Which was, like one of the worst you can do. And we're at a teaching institution. So I'm dealing with med students and residents and everything as well. And so I had a kid that was having an allergic reaction. And the resident had said that he wanted IV medicines, and so I was like, okay, and still being very new in my practice, I was like, okay, so I'm relying on you, doc, that you're telling me the right things to do, and not really in that mind of questioning things, right?
Yep.
I'm thinking, oh my gosh, I got to start a line on this kiddo, and just that anxiety and fear factor of taking care of a sick kid anyway, right?
Yeah.
I mean, and he was fairly stable, and everything, so he wasn't really that sick. But so sure enough, I got a line. I gave him his medicines, IV, and then the attending comes in right as I was just finishing flushing his line, and asked what I gave him. And I told the attending what I gave to him, and he just kind of had that look on his face like, what? And right then, you knew something. I was like, oh, crap, what did I just do, right?
What do you mean you gave the epinephrine IV?
Right? So, and the dose of Benadryl that you gave IV, that was supposed to be IM as well. I was well. So then, of course, my pecker factor, real quick, and it's like, so, but yeah, I mean, thankfully, the kid did fine and stuff, but yeah, it was definitely something I will always remember.
That'll change the way you do things, won't it? So
it totally does, right? And like I will always remember it, and like I can still picture the room that the kid was in, and like the whole setting and everything, right? It's just like an immediate flashback of what was going on and that feeling of, oh God.
Absolutely. Absolutely. And it's hard with residents. It's hard when you're in a teaching facility and you're working with residents who, they, with the sometimes limited knowledge they have, they just assume everyone's on the same page. You're like,
right.
No, maybe we need to be a little bit more specific. So, but I loved working in a teaching facility just for that reason. You get to work with people of all levels, which is always really cool. So
yeah, and it was a great place. And honestly, there's definitely times that I miss working at a teaching institution. I mean, because the nurses really have to be on your A game all the time.
Absolutely.
And it really pushes you to be the best, is because you are that safety, net for that patient.
Absolutely.
So.
Absolutely. And I think that's the case in general. I think it's more obvious in a teaching facility, of course, but I think in general, as nurses, we're always the safety net.
Oh, totally.
So.
And that's the thing. And that's what that's what I express with my staff here, and especially my newer staff that's coming on. It's like, okay, you just have to remember, it's like, the doc has, a lot of other things that are going on, right? And so as they're writing orders and things, it's like if something doesn't make sense, you're that safety net to stop and think, does this make sense? And if not, to go back and ask the questions, right?
Yep.
Just because the providers ordered it doesn't mean it's the right thing.
Yeah, absolutely. Absolutely. Tell me about a patient that has touched your heart that you'll never forget.
So there's a patient that I helped take care of that she had came in and she was in respiratory distress, history of lung cancer, and was on hospice care, and was at home. However, family, she was having increased working and breathing, and so family had called 911, so she got brought into us. And so it was very clear that she wasn't going to last long. And so we did put her on BiPAP and stuff, and we're making her as comfortable as we could, but then we had to have that conversation as what the goals of care were for her. And she had a very large family. And so trying to have the family all present and involved, in her care and that decision-making part of it as well, was truly impactful. And here, like that night, it was crazy busy in our department. And I just remember we had like trauma activations left and right. And so trying to be mindful of, I have everything else going on with all my other patients, but really being present there for her. We got her stabilized out and was able to get her admitted up to one of our inpatient beds that was for palliative care. And she passed away a couple hours later after we got her upstairs. But she was able to be comfortable and to pass away with a lot of dignity, and the family was really appreciative of that. And I got a note card from the family after the fact, thanking me for taking the time and really being able to reassure her and the family, and explaining to them what was going on. So it allowed me to know, that made that last few moments of her, the last few hours of her life, acceptable, for lack of a better term, for the family. They were able to, accept it and realize what was going on. So
yeah, that's awesome. That's one of the hardest things to deal with in the emergency department is when you know someone's not, this isn't going well, and that they need a lot more time and concern and privacy than maybe they're going to get in the emergency department. Those are one of the hardest patients to deal with.
Yeah. And unfortunately, and that's one of the things with the emergency department world, right, is that we can have that patient and the next room over is something else going, and so that's how do you balance in that chaotic environment that we work in, that we love,
yep.
And making sure that you're able to provide that level of care that we want to our patients.
Yep, absolutely. What's the best advice your parents gave you that turned out to work for nursing?
Ooh, that's a good question. I think it probably goes honestly back just to being nice and treating people the way that you want to be treated.
Yeah.
I think that's really the heart of nursing, right? Is for caring for people, and that's what we do every single day.
Every day.
And if we lose that touch, then we need to have that self-reflection of do I need to make a change myself, right? Because if we can't care for others, then what are we doing?
Yep. You're right. You're absolutely right. Okay, I'll give you an easier question. What's the best advice a nurse mentor has ever given you?
I think, definitely in the emergency department, the one thing that always stands out was just remember this is the patient's emergency and not your emergency. Right, and it really is so that you don't get wrapped up into the emotion of whatever's going on, but really to be able to step back and see the situation and know what you need to do to handle the situation.
Yeah.
And that's one of the things I stress with my new grads that are here in my department is to remind them about that. Is like, this can be the worst event in this person's life. They're looking at you to stay calm and focused and to know what to do. And so if you get worked up in that emotion of the event, whatever is going on, then you lose sight of that.
Yeah. That's true. It's their emergency. It's just your job.
Yeah.
Yeah, for sure. What advice would you give a brand new emergency nurse starting in the emergency department?
To start a journal. And write things down, those experiences that they have, those stories that patients tell you, because some of those, as we say, you can't make this stuff up.
Yep.
Right. So things that you'll see, and it's just like, it is true. It's truly an adventure working in the emergency department. We see everything from the baby being born to the person taking their last breath and everything in between.
Yeah.
And so really be able to step back and, to have a reflection kind of journal so that way you can look back and see those positive differences that you've made on people. And unfortunately, within the emergency department setting is, we'll have a sick person, we'll stabilize them, take care of them, we'll ship them off to the ICU, ship them out to another hospital. We don't always know the outcomes, right?
Yeah.
And so a lot of times the family and the patients, they don't come back to say thank you. And so we have to be able to celebrate ourselves, the impact that we've done, and support each other for that impact. So having a reflection journal allows you to be able to go back and see, the difference that you've made and the impacts that you've done.
Absolutely. That's a good idea. I've never really thought about that because there's so many, there's thousands of patients we care for, and there's hundreds of patients we'll never forget, but
Yep.
there's probably more that would be worth capturing.
Yep.
Now
And then so what I tell them is just every night after a shift, just write down something, a patient that was memorable or something that happened to you, because again, by the next day you're probably going to forget it. So
Yeah. It's true because you don't. It all becomes a blur at some point.
Yep.
So, that's crazy. I never thought about that. It's good. It's a good idea. So, what you mentioned that sometimes we hear stories from patients. Is there ever a patient story that got to you and that made you, that seems like a very specific thing that you remembered?
Well, I mean, there's always a story. I mean, is that I've had that I fell down and I slipped and fell when I was cleaning the house, and all of a sudden this whole, mop handle is up, the guy's rectum, and you're like, okay, whatever, so we've had those stories. I've had, the stories of things. The gentleman, this was a great one, that his wife was out of town, and he was at a strip club and getting a lap dance, and he got a little too aroused, and the stripper thrusted down on his lap and broke his penis, and so he comes into the emergency department, and his penis is like at a 90-degree angle, and of course he's going to have to go to surgery. And so I'm like, is there somebody that you want to call?
No,
and he's like,
nobody wants to call.
Well, no. So he says I want to call my sister.
Okay, all right.
And you're just like, okay, like.
Sure.
I don't know what you're gonna say to her, but like whatever, you're just like, okay, like I will. Let me get your phone, and like I will leave the room and let you have the privacy to talk to your sister, and you're like, okay, you play these scenarios out, like what's this conversation like, and then what's it like when his wife gets home, so yeah.
Oh, can't even imagine. You're like,
yeah, it was
well, honey, there's something that happened while you were gone.
Right.
That'd be awkward.
Right. And by the way, my first phone call was to my sister. I mean, so like.
Yeah, you just make it more awkward.
Right. Yeah, exactly.
That's funny. So one of the things that happens to every emergency nurse I know gets asked the question, like, what's the worst thing you've seen? And nobody ever really wants to know the worst thing you've seen, but they want like a go-to story of the emergency department. What's your go-to story? Like, what's your story that you're like, okay, I can't tell you the worst thing I've seen, because then we'll both be sitting here crying and that'll be awkward. But what's your kind of go-to? Here's a good snapshot of the emergency department story.
Yeah. Well, and I always can relate to this kid that I saw, and I say kid, but he was probably, I don't know, he was late teens. I don't remember his exact age, and he had got off work one night and was sitting at home outside of his house, just kind of listening to music. As he said that he wanted to kind of relax and unwind from the night prior to going inside. And somebody came up and took a AK-47 and tried to kill him.
Holy cow.
And essentially shot off half of his face.
Holy smokes.
Yeah, and so when he actually arrived to us, he was setting up, and he still had a patent airway. EMS had him setting up because all the blood was draining out, and he was kind of leaning forward. And I was like, oh my God, right, and so of course then we had to put him down and intubate him and secure his airway and everything, and and I just remember like our doctor was wanted to suction, right? And so he's using the yonker and suctioning and, making the sound. And then all of a sudden, and she's suctioning like where his essentially front sinuses would be of his brain, and it's like, and all of a sudden the yonker stops making that suction noise. And you're like, oh God, what's on the end of that, right?
Yeah, right.
So, and I just remember she pulled it back and there was, something on it, and she just kind of removes it, it kind of goes on, and, and we're packing his face with Curlex and gauze and everything, and we end up getting him rushed off to the OR, and I followed the case for several months. He actually had a really great outcome, actually, and come to find out, this kid was he was actually studying to go into medical school. He was pre-med.
Wow.
And like truly had things kind of going good in his life, and it was a mistaken identity. And he was just in the wrong place, and
Does sometimes happen.
And so it was like this guy was truly a good kid, doing his own minding his own business, and unfortunately was a victim of violence. So
it's sad. That's too bad.
So, yeah.
Interesting. One of the new questions I started asking, because someone brought it up, and I was like, that's a really good question. Have you ever felt like you witnessed a miracle in the emergency department?
Yeah, I mean, there's been several that you just can't explain, right? And so whatever your beliefs are, it's like I will always remember this one. Well, and actually this one was not even the emergency department. This was when I was working pre-hospital even, was a young kid that was at a school. The school was getting out, and he somehow slipped off the curve as the school bus was leaving, and the school bus rolled over the back tires of the school bus. So there's two tires there, rolled over his whole midsection of his body.
Oh my gosh.
And I'm like, how in the world? I mean, like this kid, I mean, he ended up having a crushed pelvis, but that was really it. Like,
wow.
How in the world did he survive? Like, I mean, he had tire tracks all across his abdomen,
yeah.
And this was it, so, and I've had cases like that. I had a 2-year-old that had a gunshot wound to the chest that coded in front of, and we were able to get him back. And, 2 days later, he's running down the hallway at the hospital with a cape on, being a superhero. And
holy smokes.
you're just like, okay, how do you, some of these things you just can't explain.
Yeah. How does this happen? Yeah.
So.
Yeah. The last question I have for you is a question that I ask everybody, and it's called 3 things. And this is one of the harder questions. What are 3 things a new nurse should remember? And what are 3 things a new ER nurse should just forget?
Ooh. So things to remember, obviously, go back to, it's the patient's emergency, not your emergency. Have a journal, write it down, so that way you have time to reflect later on. And find a good mentor. Find somebody that you can truly trust as a confidant, that you can bounce things off of. And with that, and I always try to say is, if you can connect with that mentor and do something like outside of work together as well, that builds that relationship up and allows you some stress relief essentially outside of work with somebody that you can trust, but yet they still understand fully kind of your day-to-day and what you've gone through at work.
Absolutely.
Because no matter how caring and loving your other friends are, unless they've been in this circumstance and seen what you've seen, they can't truly appreciate the things that we see and face every single day.
It's different for civilians.
Yeah.
It just is. And it's hard for them to sometimes relate. Like, you come home and you're like, I don't even want to talk about today. I don't want to talk. I just want to go to bed.
Yep.
And they're like, "What? Tell me about your day. Like, what was it stressful? What happened?" And you're like, "Oh, you have no idea."
Right.
So, yeah, it's interesting.
Yep.
So,
yeah, and then 3 things to forget. Gosh, man, that's a hard. Well, I guess forget whatever TV shows that you watched in the past, because it's nothing like it.
Yeah.
And really forget that. And this is something that I always stress, especially in the ED world, is forget that thought of that you're supposed to know everything, right? Because in the ED, we have to know a little bit about a lot of different things, but we're not masters at any of them, really, And so what you have to do is you have to know where your peers are and where those resources are to find out the information. But don't like that knowledge of, I came out of nursing school so therefore I should know it all, right?
Yep.
You got to lose that. You got to check that, because you have to be vulnerable enough to be able to say, hey, I don't know, and be able to ask the questions.
Absolutely.
Right.
Let's see. So here's a question specifically for you. So you are getting ready to take over as the president of the ENA. What's going to be your focus for the next year while you're president?
So, man, this is like a sneak peek into my presidency term,
Absolutely. Sure
my
you
platform. Yeah. So like my platform that I really ran on was, it's all about how do we give back, right? So my philosophy every single day as a manager is that I'm here to figure out what barriers my staff have to provide the best patient care possible. Nationally within ENA, that's what we have to be doing as well, is we have to figure out what resources and tools our members need so they can provide the safe and best care possible every single day. And so if that's resources that we have at the national level that we can help at the state levels and local levels for members, then what does that look like, right?
Yeah.
And, obviously continuing pushing that workplace violence, it should not hurt for us to come to work and care for our patients.
Right.
And, right. And so it's not a part of our job. It's not a part of our job to get kicked and punched at and spat at and called at, names and whatnot. And we cannot tolerate that. And as long as we tolerate it, nobody in the administration is going to fight for us. So we have to stand up and say, hey, you know what, this is not okay, and partner with our administrative staff and say, hey, how can we make this a safe environment for us to care for our patients?
I think so many ER nurses right now are focused on is the workplace violence is just crazy. It's just crazy, and sadly, it's just become so accepted as just part of the job, and it's not part of the job.
Right. So. Yeah, and with that, and especially within the ED world, and I teach my staff this all the time, is never underestimate the impact that you're going to make on somebody's life, right? And so you can have speaking especially with like a behavioral health patient, somebody that is totally off the wall, and you may not see, they may stabilize, they may get transferred out to an inpatient behavioral health unit, but you never know that little seed that you planted for them that may have made the difference for them.
Absolutely.
And so, just recently within our department, I received a letter from a patient that had been here 4 months ago, was a behavioral health patient, and she said, and she calls that out in the letter. It's like, you and your staff have no idea the impact that you truly made. She says, I don't know how I was acting in your department. I know that most likely I was not very nice to your staff. She does remember interacting with me at one point in time because we had to have a very frank conversation about behavior. And this was like on her day 2 or day 3 while she was here in the department.
Wow.
And so she really wanted to express that thanks of, that the staff that treated her as a person and let her know that, we do care for her as an individual, and as an individual person, and treat her that way, that truly did make a difference. And so she was, like I said, this was like 4 months prior, and was in drug rehab and was doing good and stuff. So, again, never underestimate that one little interaction that you have with a patient and what that outcome may be down the road.
Absolutely. That's cool. It's amazing when that happens. It just makes you feel good. It's a good feeling to know that you have just a little bit of impact on somebody.
Exactly.
So that's all my questions, my friend.
All right.
Anything you'd like to add?
Pleasure.
Anything you'd like to add? Anything you want to share with an ER nurse audience?
No, just I would say, enjoy it. It's a hard profession for us, but it's so rewarding. And always remember to pay it forward, right? Like we're very fortunate, and so how can we pay it forward to the communities that we serve?
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.